these meetings, and then I will send down there it is. That's my cue. This meeting is being recorded and will be available for you in my next newsletter. Okay, so I'm getting to think. Thank you, Patty. If y'all don't know, Patty, raise your hand. She is so awesome. She is my right arm and my left arm. Yeah. She's responsible for helping to set all of the tables up and everything like that. She's just wonderful. So thank you, Patty. And I will try to talk loud. And for any of the speakers coming up, we got to practically be right on this mic, I tell you. Anyway, I'm Mary Jane Berry. I know I've got some new folks here. I was trying to get around and see everyone, and I just haven't made it to everyone. If you're new and this is your first time, just raise your hand so I have an idea. There you go. Got a lot of new folks. People are hearing about the support group. Just as an FYI, we have almost 1,375 people on my emails. So that's how many emails go out. And yes, there's a very large percentage that are opening the emails and actually read it. And it's not only in Central Texas, but it is nationally. But we're just trying to share the information and work with all of the support groups. And we've got a wonderful one in Temple, that's BAPS, which is the Bell County. And I think Gail, stand up. This is Gail, sure, and she runs that group, and that is the one there in the Temple area, Bell County. And Colleen. All right, thank you. And then there's also, we're close partners with Austin. Austin is known as CAPS. And I thought I'd seen Christy here, but I guess not. But we do have one of the board members, and this is Kara, one of the board members from CAPS. And so we all work together because with Parkinson's, we're all on the same team to help each other. All right. I want to be sure and thank my Zoom team in the very back that's going to be recording this. They're just great, and I appreciate them very much. And door prizes, just to let you know in advance. There's door prizes after the end. That's a pretty good one. So if you did not get a door prize ticket, be sure you get up and go get a door prize ticket. And my husband is back there giving them out. And if he promises you a new car, well, we don't have it. He watches Prices Right too much, and he's always trying to do a new car. Anyway, so be sure you get your ticket. Okay, the agenda for today's meeting, you can pretty much see it, is just the social. So some of you may have wondered, the 2:30 time frame, 2:30 to 3 o'clock is the social time, a chance for you just to kind of meet and talk to folks and just to get together and talk to our sponsors. Excuse me. Then I'll come right in as I am now doing some announcements, which we'll go through. Our speaker is awesome. He's already here. Came here from Temple, part of Baylor Scott and White group, and you'll get to hear him. And then at the very, very end, we will do a quick exercise segment, which is great. So moving right along, flu shot clinic. I mentioned it already. Feel free to go back there and get your flu shot. It's Liberty Pharmacy that are bringing them to you, and enough said there. The t-shirts, these are our brand new t-shirts, and we have some available back there. If you've already ordered one, we may already have one for you. If you would like to order one, you can. And as you can see, the red, but then on the back, curably optimistic, and that's what we are. Take off a little bit from the Michael J. Fox book, but it is just really how we feel and what we want to provide as a support group, that we are optimistic. So feel free to go get a t-shirt. Sponsors, awesome sponsors. I couldn't do this without the sponsors' help. They help us financially in order to make sure that we can get our meeting facilities, as well as to help get the refreshments and to pay our instructors. And you're going to hear about our instructors here in just a few minutes. But just to let you know, the first one I want to share is Medtronic, and they can wave their hand. Medtronic is around here somewhere. I think it's those handsome fellas in the back somewhere. Anyway, Medtronic, y'all raise your hands. There they are. I knew. I tell you, I don't know what it is. These pharmaceutical companies get some of the most handsome men and beautiful women. It's just amazing. That must be a prerequisite. But anyway, Medtronic is one of our sponsors. Then we also have Abbott. Abbott is one of our sponsors too. And I believe that's Damon back there in the back too. You can wave his hand. So if you want to talk to any of these fellas, or women, by all means, go up there and really learn more about maybe the medication you're on or the DBS unit that you're using. This is where you're getting to really speak to the people. We also have representative from Arcadia, which is New Placid, is Amy. Amy's over here. She's got her hand up there. So feel free to talk to her about that product. In addition, we have Imbresia, which is part of the thing with Antonio, with Accorda. I don't see him here today. So I guess he didn't make it, but he usually comes. But we have Will. Will is with Sopranos. All right. We got Whit there. He's always very, very good. Oh, and even Gardenia with Parkinson is giving him the Vanna White. So that's wonderful. Okay. Moving right along. Boston Scientific. Boston Scientific is here also. There they are over there. That's Rosemary. So again, another one. Y'all be sure and check them out. And then coming, we also have Insight Tech. Insight Tech is with Kara. Kara's right over here. And if you want to learn more about any of these products that are treatment options for Parkinson's, these are the people to talk to that you can just really learn. Abby is also here. Where is Abby? Abby is with Erin Clark, and I don't see her offhand, but she is also one of our sponsors. And Grand Living is one of our sponsors. Grand Living is that very nice retirement community that's just right before you get to the church on the left-hand side. As look at 35, it's on the left-hand side. It's called the Grand Living. This is where we have our educational luncheons. And the educational luncheons are free. And this is where your pharmaceutical reps can do a branded talk. So if you look over here, we've got one coming up, October the 13th. It is totally free. It's a nice luncheon. And Abby is going to be putting that on. And Dr. Swallow will be your speaker. So I highly recommend if you want to come to learn a little bit more, by all means, about Parkinson's, and then he'll also share with you specifically more about Duopa. So be sure you register. This is also in my emails, as well as in the newsletter that I sent out. For y'all that are brand new, I do send out a newsletter and an email. Try to do it weekly to get the information out. So by all means, if you have not received any of this, be sure you sign up in the back so I can add you to our list so you can get all this information and sign up. Okay, I want to tell you about this. This is I wish I could get rid of this thing, but there it is. Wait, let me see. Okay, I'm gonna come over here, hide. There we go. Okay, and now there's another one there, but maybe it'll go. Okay. Anyway, this one is an annual dementia seminar. Just to let you know, GAPS, I have partnered with another group, part of the worship place, and we are going to be doing a talk October the 3rd. So on October the 3rd from 6 to 8 p.m. it's totally free on the Sun City campus. If you would like to come to this presentation, you can. You don't have to sign up, just show up. It's from 6 to 8. Dr. Benj will be the speaker. And for some of you who've been with the group a while, you may have heard Dr. Benj. He's a very good supporter of GAPS, and it's going to be very, very interesting. So I want to share about that. Caregivers. You know, many of us are caregivers. I'm a caregiver. For some of you who don't know, again, who are new, my husband's doing a door prizes. He's had diagnosed with Parkinson for 16 years. But like many of you, and like we know, you have Parkinson's way before you were ever diagnosed. The symptoms were way before. We can actually trace back his symptoms now 10 years prior. So we say over 20 plus years we've been living with Parkinson's. But the point I'm going to make is I'm a caregiver too. And we have a great caregiver group. We meet on the second Thursday of every month. And you might think it's, oh, sad or whatever, but there's a lot of laughter going on in the caregiver group because we just share stories. And it's open to men as well as to women. So I want to encourage you to be sure if you'd like to come. But the main thing I want to point out is there is going to be a caregiver training camp. This is in my email. This is going to be on October the 12th. Also, right there at the worship place. No, this is going to be in Sun City. This one's going to be at the Longhorn Room. So it's going to be in Sun City. It's for caregivers, and it's a great way to learn a lot of information. They're going to have speakers, and it'll be really, really good. And it's free, but you need to sign up. So be sure you check that out. And we just wanted to let you know that you're not alone. And of course, many of you guys already know my mantra that I kind of created for our support group: to educate, exercise, and socialize. So that's part of the reason why we meet here at 2:30 to socialize prior to the meeting starting at 3. And it's why we end our meeting with exercise, but that's why we have exercise classes that we offer free. And of course, the education is our wonderful speaker that we're going to be hearing in a minute, as soon as I get off. But I want to talk about exercise real quick. We offer free of charge voice therapy. It's exercise, voice exercise, as well as music therapy. And the voice exercise is taught by a speech therapist, JD Bush. And yes, and she's really, really good. She's usually here. Oh, and we'll stand up, Miss JD. Yeah, stand up, stand up. JD teaches, yes, our speech therapy on the 2nd and 4th. Occasionally, though, we alter the months. And so for the month of October, she will only be on the 2nd and 5th. But when the weeks she is not there, we've got something really cool we're doing. We sing. Now, for some of you that have come to it, you go, oh yeah, singing, Mary Jane, you lead singing, it's not very good. Well, that's true. I'm not a very good singer. I make joyful noise. But I now have 2 professional singers that we're going to be leading our music therapy classes. So if they would stand up for me, please. I have got these 2 gals, and I'm going to go right there. They are. I've got Catherine and Susan, and y'all can wave. And anyway, they are going to be leading the singing in our classes. So I really want to encourage you guys to come. And so we can really have even a lot more fun. So thank you, girls. Thank you so much. And let me see if I can go back here. Yes. The other thing is we have chair yoga. But then right after, and a chair yoga is great. We meet over at the Church of Christ. Really good. I encourage you to go to that one. That's every Wednesday at 11:30. And also, just to let you know, right after that class on chair yoga, we have Power for Parkinson's. I'm going to tell you about that in just a minute. There we go. It's over there. And I've got a whole slide for you guys, so I will come back to y'all. We also play ping pong. We got some ping pong players. Who all plays ping pong? Raise your hand. Okay, you can see we got some ping pong players here, and it's really a lot of fun. And they're getting together every Thursday. And that is going to be, excellent question, at the Georgetown Rec Center, right here in Georgetown. Now, there is one in Austin also. There's a ping pong group in Austin too. But that's the one right there that we have is in Georgetown. Okay, the next one is painting with Parkinson's. How many people have done the painting with Parkinson's already? Raise your hand. Yeah, it's really fun. It's fun. Did you bring your art? Nope. Wait, no. Whoa. It is really fun. And that, again, is free classes that we're offering. Okay, and then I wanted to share, I shared about singers, but at the bottom half of this slide, I hope you guys can see it. It's a little hard. This is where Angie, raise your hand. Angie and Garden are with Power for Parkinson's, and they have come all the way up here to Georgetown. We want to say thank you. And they offer this class every Wednesday at 1 o'clock. It's a wonderful class. I encourage you to go. And if you're in luck, Angie will be leading our exercise segment after our doctor speaks. So that's coming up. All righty. Just a reminder, though, no yoga on October 4th. The instructor is going to be gone. The 9th and the 30th, which is the, yeah. Oh, they're pointing to something. Oh, yes. Well, I've got a slide for it. Yeah. Oh, they didn't want me to leave somebody out, and I haven't. I'll give him special billing here in just a second. But bottom line is, on the 9th and 30th, vocal exercise, that's going to be the first, let me see, 2nd and 5th for JD. And then on the 2nd, 16th, and the 23rd of the month is going to be our singers. But then we have Texas State University. I hadn't forgotten, Mr. Jason. Come on up, sir, if he wants to. We are very, very fortunate that we have also partnered with Texas State University. This is the communications department. This is Jason, who is the instructor, main instructor and clinical professor. And he has offered to let anyone come to some classes to work with his students. So I'll let you talk. Dr. Brian.
All right, I'll be very brief. My name is Jason Tibbs. I am a speech pathologist. I'm also a clinical educator at Texas State University in Round Rock. And we have speech services for individuals across the lifespan. And we also have some programs specifically designed for individuals with Parkinson's. I know some of you guys out there, I see some familiar faces. So if you would like any more information, seek me out. I'll be around and be happy to talk with you a little bit about what we do at Texas State. Thanks, guys.
Thank you. Okay, and now let's see the next slide. Oh, the next slide I have, and I'd like to introduce this person. This person is Chris Lyon. Chris Lyon is he's a good friend, and I met him when he called me one day, and he just called me up and said, "I'd like to talk to some people about Parkinson's." And I introduced him to another great person, Bob, who happens to be standing right up there. And these two guys have gotten together, and now Chris has really done something really cool with his Parkinson non-support group. So come on up, our nonprofit group. I'll let you tell them. And talk right into it.
Right in there, okay. Hello. First of all, I personally want to thank Mary Jane because she really is a force of nature, and I suppose that you all, you don't need me to tell you what a wonderful person that she is, and what a blessing she has been for me personally. She already mentioned Bob. I wasn't going to tell the story. Since she mentioned Bob, I'll say that Mary Jane introduced me to Bob, and Bob has been a real inspirational person to me as well. Bob has run a bunch of marathons, and I was always very active. And so when I first called Mary Jane, and she introduced me to Bob, I called Bob and said, "Hey, Bob, I was diagnosed with Parkinson's a few weeks ago, and I'm depressed, and I've got these teenage kids, and my marriage is falling apart." So I said, "What do you say, Bob? Do you want to get together and talk about Parkinson's?" And Bob said, "No." He said, "I want to meet you for a 5-mile run." And so Bob, put me on the path where I am today, which I think I am almost 6 years in with this disease, and I feel good and I'm happy and motivated, and between the exercise that I've done also, and I will say as well that the art has been a real big important thing. When I was younger, I used to feel like art was just sort of decoration. It was just sort of something that you did with your free time, and that was that, and it was all very nice. But because of Parkinson's, it's really reoriented the way that I think about art, because now I feel like it's the other way around. It's not that art is just really decoration for life. The way that I think about art now is that we work so that we can express ourselves, and a big part of that is art. Art is a wonderful thing, and I think those of you who have been doing painting because of Parkinson's and so forth, maybe you've discovered this as well. Another thing that I would say about the connection between art and Parkinson's in particular is that, it's not just a mashup. When we talk about art and Parkinson's, it's not these two random things. It's not like, it's more like, here's what I'll say, it's more like peanut butter and chocolate, right? These are two things that go together. I myself, post-diagnosis, I'd always loved poetry, but it wasn't really until post-diagnosis that I really started writing poetry. Maybe you guys have experienced some of the same thing in your own lives. Maybe it's not poetry, maybe it's painting or some other forms of artistic expression. So that's what led me to start the Quiver about, it's been about 4 years now. I have my business cards here if anybody would like a business card. But the Quiver is focused on this connection there between art and Parkinson's. We try and offer programming for people with Parkinson's and art. For example, right now as we speak, there's a online 8-week poetry workshop going on as well. And we do painting workshops as well, all kinds of things. But the art show is our big annual event. It's coming up October 14th. It's going to be at an art studio downtown Austin. Something Cool Galleries. There is a fee for those of you that can afford that, but that's fine as well. People with Parkinson's and their caregivers are allowed to come for zero mission fee. But if you can, I'd hope you would at least consider paying the fee. And if you can't, or either way, what I would do is I would hope that each of you could help me in one small way in terms of marketing the show, and that is to go to this website called do512.com. It's focused on things to do in Austin. And if each of you, even right now, or before you leave the meeting today, if you could open up your phone, go to, there we go. You go to do512.com, search for the Quiver or the art show, and then upvote me, which means upvote the show, which means so that it will appear higher in the list of things, higher in the list of activities for the weekend, to ensure that other people can see it. It's a busy weekend, October 14th. And so any help that you can do, and also spread the word to your friends. So I do have several pieces of art. Mary Jane before was talking about getting the Vanna White treatment. So here we've got the lovely Bob and here's some Vanna White. So this is first painting. And by the way, I will say this, that it's an international art show, and in particular, what that means is I'm going to have art from 5 continents and 8 countries there. And so you'll see just a few. This obviously is just a small random sample. We'll have 60 pieces of art there, 30 to be auctioned. I will have a professional art auction there at this show. It's going to be, by the way, also, I cannot stress this enough. Also, there's going to be open bar as well. Yeah. So open bar. But anyway, so the first piece is by her name is Karina Limos. She's from Mexico, and this is sort of the as you can see up here at the header thing. Karina, I asked her to do these sort of the theme art for the show. That's what this is here. The theme for the show, by the way, is kaleidoscope, the kaleidoscope. And so that was her sort of own interpretation of what the kaleidoscope meant for her. And again, and in case I didn't make this clear, all this art is by people with Parkinson's. This one here is Bob Bernard. He lives in the UK. He's a wonderful painter, career landscape painter, and he's continuing to paint these days. And the last one there is, her name is Sue Bird. She's from Australia, and she does these wonderful, uplifting. For a long time she did kiwis, but now she seems to be kind of on an elephant kick, elephant motif. And so again, you see 3 very different styles. It's a small selection. I think I've got, again, about 60 to 70 paintings there. So it's just 3 of them, obviously. About 15 artists from around the world. Again, October 14th in Austin. Any questions? Anything coming to mind in terms of the show or the Quiver or anything else? Yes, ma'am. This is strictly going to be an in-person event. Yes, so tickets, thank you for asking that very question. So the tickets are available online at eventbrite.com. There's a variety of ways to get there. Maybe it might be best if you go to Do512, since y'all are going to be going to Do512 anyway to upload the show. And then from there, say buy tickets. Click there, and then from there, it'll direct you to the Eventbrite site to buy the tickets. Tickets are $40, but then again, we'll have a DJ there. And also, again, as I say, there will be an open bar there as well. Any other questions? All right, so I hope to see you all October 14th in Austin. Be there, be square. Okay, thank you, Mary Jane.
Thank you, Fred. If you give me that link, I'll put it in the newsletter too. So consider that done. Thank you, thank you. All right, now it's time for the speaker. And we are just so excited. I actually had an opportunity to hear Dr. Shawagfeh. That's all right. Anyway, I heard him at the Bell County, the BAPS meeting. It was so interesting, just his presentation on Parkinson, and I learned a lot of stuff. And it's one thing about Parkinson's, we already say, is when you see one person with Parkinson's, you see one person with Parkinson's. And everybody has kind of a different journey. But at the same time, he presented a lot of extra facts that I did not even know about. Dr. Shawagfeh is the clinical professor at Texas A&M, College of Medicine, Department of Neurology. He's also the director of the Baylor Scott White Plummer Movement Disorder Center. And gosh, his education is medical school in the University of Jordan. Then he went to UTMB branch in Galveston for internship. That's where I went to school too, UTMB in Galveston. Yeah. And then he also did neurology there in Oregon. He went to Oregon and did neuromuscular medicine. And then University of Washington Medical Center fellowship in movement disorders. And he is also board of psychiatry and neurology. My gosh, neuromuscular. This gentleman is very well trained. So thank you, sir. If you'll come on up, I'll get your slides ready. Round of applause. Okay.
Good afternoon, ladies and gentlemen. Thank you for having me today. You can hear me well? Hear me well?
Okay.
Now you can hear me? Okay, excellent. Thank you for having me today. I joined Baylor Cat and White back in 2019. I came to Central Texas 4 years ago.
It's got to be right up there. I mean.
Okay, really close. Oh, great. So I joined Baylor Cat and White back in 2019. Was included there to fill the position as a movement disorder specialist, mostly seeing patients with Parkinson's disease, but seeing patients also with other movement disorders. So most of my patients that I've been seeing over the last 4 years are patients with Parkinson's disease. So I started there back in September of 2019. Guess what? A few months later, the pandemic started, gave one speech, and after that, we went into the hiatus up until last year. This is when I gave the second speech that was at the Bed County a few months ago, and now this is the third one. So I've met already with a few patients that I've been seeing for the last couple of years. So again, thank you so much for having me today. So I'm going to have a little talk about Parkinson's disease.
Okay. I got to do a share screen for you real quick. Okay. Get that.
So as you can see up there, that's our guy. Parkinson's. By occupation, he was actually an English surgeon and politician. All right. So which has nothing to do with Parkinson's disease. So this guy wrote his famous essay back in 1817. That's 206 years ago. The shaking palsy. He described a few cases, like 5 or 6 patients. Some of them were his patients, some of them they were not, just people who were just walking the streets of London back then. Describing the way that they were walking, the way that they were talking, their exam. He did something that nowadays it's like an art, what we call neurological examination, physical examination. He wrote this and he named it the shaking palsy or paralysis agitans. He tried at that time treating these patients unconventional with like venesection, reducing brain pressure as a surgeon. Then fast forward for like 5 decades down the road. So as you can see here, this is a famous portrait for neurologists and psychiatrists. Back in 1860s, this is when Jean Martin Charcot, that is one famous neurologist and psychiatrist. He considers himself and even his students considered him as the greatest neurologist of all time. So Charcot here in this famous portrait, this lady, by the way, she just has hysteria, so it has nothing to do with Parkinson's disease. Now he's teaching a lot of famous neurologists, like Charcot, the guy who's holding the lady, okay, one of his students, Babinski. And if you see this guy here scratching his head like a smart fellow, that's Tourette. Have you ever seen someone with Tourette disease or heard about Tourette disease? That's Tourette. That's one of his students. Okay. So Tourette, Marie, Babinski, all of them, Bordenstein, were students of Charcot. So Charcot took the work of James Parkinson. He saw a lot of patients, many patients with Parkinson's disease or with paralysis agitans. He's the one who determined that there is really no paralysis in these patients. Because Parkinson's at that time, James Parkinson thought that these patients were like having a stroke or a primary muscle disease. So this is why he was treating them with venesection and all these interventions. But Charcot determined that there is really no weakness. These patients are not really weak. They have good normal muscle bulk, but mostly stiff and slow. Didn't know what to call it, so he called it Parkinson's disease. So Charcot called the disease Parkinson's disease. He worked with his students on seeing patients, and they actually started treating patients medically with medications that some of the medications that we use nowadays are actually derivatives from the same plants, okay, that Charcot used to treat his patients with. like alkaloid belladonna, which contains anticholinergics. If you've been on medications like benzotropin or Artane, trihexyphenidyl, or Cogentin, they're from the same family of medications. So after that, Alzheimer's and Lewy. Alzheimer's disease, we are all aware about Alzheimer's disease, which is the most common type of dementia that was named after Alois Alzheimer. In Germany, with one of his students, Friedrich Lewy, they were working on treatment, management, and diagnosing patients with dementia. That was back again in Germany. That was in the early 19th century. And this is when Friedrich Lewy, the student of Alois Alzheimer, determined the main pathology in patients with Parkinson's disease, which is Lewy bodies in the brain tissue of these patients. Now, collectively, we call Parkinson's disease and Lewy body dementia together as Lewy body disease. They were unable to find specific treatment at that time until the 1950s, 1960s, when a group of scientists, Orny Kaiwix and his colleagues, they started by doing brain autopsies in patients with Parkinson's disease, patients with the Lewy body dementia, with the development of technology of microscopy and immunostaining. They were able to determine that the disease starts in a specific area in the brain that's responsible for the transmission of a chemical in the brain that's dopamine. Now, the question, how to isolate the dopamine, how to synthesize the dopamine, and how to deliver it. So they started doing this, trying to do it intravenously by injection, but the effect of the dopamine was not long lasting, with a lot of side effects that come with intravenous dopamine. It wasn't until the late 1960s when a form of the dopamine or a precursor of the dopamine was made, synthesized, which we are still using it until now. Most of our patients with Parkinson's disease are either on or have been on this medication, which is levodopa, carbidopa, levodopa, or Senate. It got approved back in 1969 for patients with Parkinson's disease. If you watch the movie Awakening, Robin Williams and Robert De Niro, it talked about this catatonic patient who started becoming more mobile, active, verbalizing. Okay? It talks specifically about this medication. It was about the time that this medication was approved for patients with Parkinson's disease, 1969, carbidopa, levodopa, or Senate. So here, this is Friedrich Lewy. As you can see, this is Alois Alzheimer, and this is Friedrich Lewy in the lab in Germany. What you see here, the sample, the pathological sample or the brain tissue sample, this is the Lewy body. This is what typically neuropathologists see in the brain of patients with Parkinson's disease. So Parkinson's disease is divided simply patients when they present to the clinic with Parkinson's disease, specifically complaining of what we call the motor symptoms, while Parkinson's disease in reality is much bigger than just simply motor symptoms. We take the patient as a whole. Most of the patients, when they come to the movement disorder clinic, most of the time they're complaining about tremor, stiffness, slowing of the movement, loss or impaired dexterity, sometimes balance issues, difficulty taking steps. While if we dig deep with the patient, the family members, caregivers, there are other issues that might have been going on for not years, but sometimes even decades before that, that are actually part of the non-motor features of patients with Parkinson's disease, and they are related directly to the same pathology that's causing the motor features. It's quite often for patients with Parkinson's disease to have lost their sense of smell, years, months, decades, or at least some impairment of the sense of smell. Problems with bowel movements, constipation, problems with early satiety. They feel full early after they take a couple of bites. Same thing with speech, softening of the tone of their speech, which goes hand by hand when we We use the same set of muscles for speech and swallowing. Patients, when they start noticing that their speech tone has lessened, at around the same time, this is when they start feeling that they have some difficulty in swallowing, especially when it comes to liquids or their own saliva.
Made it a little bit bigger for me.
Same thing. Patients with Parkinson's disease, they might start having problems with the automatic responses. We call it neurology, autonomic nervous system. This, while it also includes constipation, it can affect also problems with urination, problems with sweating, problems with blood pressure and heart rate control. So it's quite often patients will complain when they stand up after especially sitting or laying flat for a long period of time, that when they stand up, they feel lightheaded, dizzy, as if they're going to pass out. Cognitive issues. Patients with Parkinson's disease in general, they don't develop the same frank dementia or the straightforward dementia that we expect to see in patients with Alzheimer's disease. The same way that patients with Parkinson's disease are slow in their movements. Well, this is the essence of Parkinsonism, which is bradykinesia. Bradykinesia means simply slowness of the movement. The same thing can happen
Gypsy, come on,
with the thinking, processing the information.
go pee pee.
So the information is there, but it takes longer than usual to retrieve or verbalize this information out. We call this psychomotor slowing. So with clues, giving patients clues, they usually are able to answer questions, or by giving them hints, they are able to give the information out. All what it takes is just to be patient. It takes longer than usual, but at the end, they are able to verbalize. This might progress. It's not a package. It doesn't mean that's going to happen. And when you see this iceberg, it doesn't mean it's a package that every single symptom is going to happen to patients with Parkinson's disease. As we said earlier, every patient is different. With this form of psychomotor slowing, the best way always we ask patients, while you might feel that you have the tip of the tongue information, or you feel that you know the answer, but you cannot verbalize it. Don't put yourself in a vicious circle. Just take your time, concentrate, focus, and you will be able to give the answer out. Same thing when we ask patients, you're doing physical therapy, doing these exercises, range of motion exercises, walking around, doing stationary biking, doing aquatic therapy. The same thing can happen to the mind, solving puzzles, reading, staying socially active. It's among the things that keep the neuroplasticity, wiring of the neurons, of the neuronal pathways in patients with Parkinson's disease to help slow the disease progression down the road. Mental health issues can be also part of the presentation of patients with Parkinson's disease. It might actually start years before the formal diagnosis or where the motor symptoms have become noticeable. This includes depression, anxiety. It's not because of the diagnosis, not because they now know that they have Parkinson's disease, but this could be also related to the neurological or the neuropathology effect of Parkinsonism on the brain itself that led to depression and anxiety. Hallucinations, especially most of the time in patients with Parkinson's disease, is not really the frank, well-formed hallucinations that we see in patients with schizophrenia or patients with the drug-induced hallucinations or what we expect to see in Lewy body dementia. But most of the time, patients will see what we call passing by shadow or feel of presence. It's quite often that patients with Parkinson's disease, they feel that there is something going on the same side where they have the tremors, where they have the stiffness, where they have the slowing of the movement. There are different interventions that have been approved and cleared to help patients with Parkinson's disease. With this being said, I'm going to go through a couple of slides about these available interventions. But remember, the most important single thing for patients with Parkinson's disease that I keep reminding myself and my patients of is to stay physically and mentally active. If there is anything that's going to slow the disease progression, is to use it. It's use it or lose it. So physically, we don't ask patients, while we encourage them if they are interested in boxing, but not like professional boxing, but boxing classes. But what we are asking for is range of motion exercises, walking in open spaces, as long as safe to walk outside, especially in this nice weather in Texas. Now it's 102 when I was driving from Temple. The temperature is 102, and today is September 28th. Oh. So, walking, aquatic therapy, biking or stationary biking, even pedaling in place. This helps the most when it comes to the stiffness, when it comes to the slowing, okay, of the muscles or the joints, hips or pelvis, knees and ankles. Walking, swinging the arm, especially if you walk with a partner, with a chaperone, there's someone who can nag on you, okay, to keep swinging your arms. Most of the time, patients, when they walk in the hallway, they forget to swing their arms, okay? And you remind them, and a few seconds later, the arm goes in its place, rigid, stiff. So this typically ends up in what we call frozen shoulder, okay, which actually there is like an inflammation and adhesion in the capsule of the shoulder joint, which is a painful condition. We don't want this to happen. This is why we need to get physical therapy, range of motion, stretching exercises. I can't count how many or tell you how many patients have undergone unnecessary surgery for rotator cuff or shoulder joint replacement simply because they have a frozen shoulder that could have been treated easily with just range of motion exercises earlier. Most patients, we don't keep thinking that, am I swinging my arms? So it's an automatic response. This is why I'm saying it's better to go out, walk in a nice weather, open space, while there is someone else can remind us, okay, to swing our arms. Okay. Usually if we walk inside closed spaces, we don't have this enough space to swing our arms. This is why I encourage to go outside, to walk and swing the arms. So these are the FDA-approved interventions or medications or treatments for patients with Parkinson's. On top of the list, you'll see the carbidopa-levodopa, which comes in many different formulations. As we said, it's been approved back in 1969, yet it's considered one of the most effective treatments available to help the symptoms of Parkinson's disease. I'm saying this because even nowadays, the big movement disorder centers, it's considered not as just treatment, but as part of the diagnosis. Most of you, if not all of you, when they've been diagnosed with Parkinson's disease, the neurologist or whoever provided the diagnosis wanted you to be tried this medication. Then you come back and see how you're doing on the medication. It's what we call both therapeutic and diagnostic. There are many chemicals, not just one chemical, not one neurotransmitter that's deficient in patients with Parkinson's disease, but that's the main one, the dopamine. And this is what the levodopa is trying to replace, trying to boost, trying to help with improving the symptoms, mostly when it comes to the motor symptoms, comes to the tremors, comes to the stiffness, comes to the slowing of the movement, or what we call the bradykinesia. Now, different formulation. We have the immediate release formulation that patients have to take several times a day. The continuous release that patients can take less often, maybe at bedtime. The extended release, the capsule version that got approved back in 2014, the Rytary. We have also the daily, that's a squirt formulation, because some patients might take half a pill, quarter pill, 3/4 a pill of the levodopa to give the benefit rather than getting the side effect of the medication. So the daily got cleared or approved by the FDA just a couple of years ago. Now we have the Embrasia. Embrasia is still levodopa, but it's an inhalation. It's like a rescue medication that patients use on as needed basis if they're wearing off between the doses. Levodopa, once it gets converted into dopamine inside the brain, it doesn't last long. Okay? Whether you're talking immediate release or even the extended release, the difference is not that long. So fluctuation, wearing off, where basically patients can move from being on, having good time, the tremors are under good control, they're not having much of the stiffness, might have a little bit of dyskinesia, like Michael J. Fox, that the way that he's walking, he's moving, that's the levodopa-induced dyskinesia, that's the effect of the medication, or moving toward the off episodes, where they're having more of the tremors, the stiffness, the slowing of the movement. So when they get these off episodes, they either need to take a medication or medications to help the carbidopa levodopa for their treatment to last longer, or take another medication on an as-needed basis just to bridge this time until they are due for the following or the upcoming dose. So among these medications is the Embrasia, which is still levodopa, but it comes as an inhaler, right? The dosage of carbidopa, that's really not the medication for Parkinson's disease, but to treat the side effect of one of the medications, which is the carbidopa levodopa. Not sure how often feel this, but statistically speaking, one out of 10 of patients with Parkinson's disease, when they start the carbidopa levodopa or when they start increasing the dose, might feel nauseated. Guess what? The nausea reflex is mediated by the dopamine in the brain. So that's a normal side effect or expected side effect of the levodopa or the dopamine or the dopamine. So if we have toxins, food, expired food or something, and we want to throw up, the brain, the area in the brain that senses that there are toxins in the stomach is actually mediated through dopamine, sends signals to the stomach to throw up. So we're giving you dopamine, okay? So it's going directly to your stomach. So you'll expect that nausea might be a side effect of this medication. So what the carbidopa does, the docin, it basically tries to prevent the levodopa from getting into the blood or get transformed from levodopa to dopamine in the blood, but let it go to the brain. Let's do its job in the brain. So you to be used where we wanted it to be, okay, to the brain cells, rather than working in your blood, in your gut, causing the nausea and vomiting. Other medications basically trying to enhance and make these medications last longer by preventing the breakdown of the levodopa. Whenever you take the levodopa, theoretically, the half-life is just for a couple of hours, okay? You do have your own dopamine, and this levodopa is trying to boost the dopamine in your brain. So if we give other medications that slow the breakdown of the levodopa, it might make it last longer by preventing or blocking the enzymes. There are a couple of enzymes. They are in the blood, they are in the brain. We wanted the levodopa. We cannot inhibit the levodopa inside the brain, but at least inhibit or slow the breakdown in the blood. So two enzymes, one of them is COMT, which is catechol methyltransferase. So if we are able to inhibit it, and there is a long list of medications, Comtan, Stalevo, Tasma, and the newer one, which is opicapone, Ongentys. The newer one, Ongentys, carries the advantage that it's given only once daily, while the other ones have to be given several times during the day. The other enzyme, which is the MAOB, which is monoamine oxidase inhibitor, so you try also to block it. Several medications include selagelin, razagelin, and Xadago, safinamide. Razagelin and safinamide, Xadago, they are given once daily. Selagelin can be given once or twice daily. Now, levodopa gets into the brain, has to work in a certain area in the brain that's called the dopamine receptors. It's produced in an area in the brain at the back of the brain called the brainstem or the midbrain. It's called substantia nigra, the black matter. Okay, and then it goes inside the brain, deep area in the brain that's called the basal ganglia. This area is rich in dopamine receptors. When some of you guys have gone to do the DAT scan, the AT scan, which stands for dopamine transporter scan, what they are actually doing when they give the contrast, they're looking actually at the concentration of the dopamine transport. That's the AT. Okay, that's the basal ganglia, that's deep in the brain, right? So these are the area that's rich in the dopamine receptors. And these are the area that starts to degenerate early in patients with Parkinson's disease, among other Parkinson's lookalike or atypical Parkinsonism, not just unique to Parkinson's disease. So the dopamine goes to work at the receptors in the area in the brain that's called the basal ganglia. So why don't we try to develop other medications that mimic or look like dopamine, what we call dopamine agonists or dopamine lookalike? We do have a few of them, and this includes medications like Neurology, pramipexole, propranolol, or Liquid. protigotine or Neuropatch. Mirapex are ropeneol, they like dopamine, like levodopa, they have short half-life, so they have to be dosed several times a day, 2-3 times a day, while the Neuropatch is just once a day, but it comes in different doses, from 1 milligram all the way up to 12 milligrams a day. The other forms of dopamine agonists that can be used on as-needed basis is apomorphine. It has no morphine in it. So the apomorphine is a dopamine agonist. It's actually an old medication. And one of the things that they used to do in the old days, before I did my residency and fellowship, that when someone comes to the clinic and they think he might have Parkinson's, what they will do is the apomorphine challenge test. They will actually inject the patient, okay, with apomorphine, okay, and see if this helps with the tremors, okay. Quick, but at the end, patients will start throwing up, okay, with low blood pressure. Okay, it's still done, rarely, but apomorphine can be used as a subcutaneous injection on as-needed basis, as a rescue medication, the same way that we talked about Embrasia, the inhaler, but this one comes as an injection, 3, 4, up to 5 times a day, as-needed basis, when patients have these off episodes of the tremors, the stiffness, or the slowing of the movement. The other form of apomorphine, which is relatively new, which is the Kinmol. This is a sublingual gel, right? You put under the tongue, same thing, same principle. The effect of these typically is to bridge patients. Depends on how much you have in your system, in your blood, in your hair. The effect might last anywhere from half an hour, it might last to 1.5 or even up to 2 hours, okay? To bridge you up for the next dose. Now, they're working, while I believe this has been approved in Europe, they're still working, trying to approve a subcutaneous infusion, continuous infusion of the apomorphine through a pump for patients with Parkinson's disease. Amantadine works on a different level for patients with Parkinson's disease. Amantadine is actually originally is an antiviral. They used to treat influenza with amantadine. There's amantadine and amantadine. Now, amantadine has been used for patients with Parkinson's disease for a long time to help treat mild tremors, mild symptoms, but they found that amantadine actually helps the most, not with the Parkinson's part, but with the byproduct of the medication, which is the levodopa-induced dyskinesia. Remember, we talked about Michael J. Fox with the dyskinesia, where they're having these involuntary dancing movements. Seems like the amantadine seems to help lessening these movements, and this is why they developed, engineered the long-acting version of amantadine, which is called Glucovin. It's basically approved by the FDA to help patients with levodopa-induced dyskinesia. The other new medication, which is estradiol, Neurology. This works at the adenosine receptor. You know what else works at the adenosine receptors in the brain? A very common thing that you probably all of you had today, this morning. Coffee, caffeine. Caffeine works at the adenosine receptors. Okay. Adenosine is a potent neurotransmitter that actually helps initiate sleep. Caffeine blocks the adenosine receptors. This is why we stay awake with coffee. But depends on how much we have turnover of the adenosine receptors and how much we are metabolizers of caffeine. Some of us will feel actually awake and alert when we drink coffee. Some of us, we don't. It doesn't really matter much. Okay? So adenosine estradiol has been approved by the FDA back in 2018 or 2017. I don't remember exactly, for patients with Parkinson's disease. And it helps. It's once daily medication. That's one of the advantages. It's taken at 2 doses, either 20 or 40 milligrams once daily in the morning. It has actually a very long half-life. Actually, it lasts for several days, 3, 4, or even sometimes 5 days, depends on how rapid metabolizer or how the metabolism of the patient, him or herself. It helps smoothing out these off episodes where patients having a lot of the fluctuation, where they're having the tremors and the stiffness. The medication, the last one here, number 9, that's pimavanserin. This medication also has been approved by the FDA for patients with Parkinson's disease to help with one of the symptoms, not related to the motor symptoms, not related to the tremors, the stiffness, or the slowing of the movement or the gait, but to help with Parkinson's disease related psychosis. When we say the word psychosis, we mean two things: delusions, abnormal thoughts, and hallucinations. Typically, most common in patients with Parkinson's disease, we're talking about visual hallucinations. At the beginning, this was my understanding up until 30 minutes ago, that this medication was approved for patients with Parkinson's disease psychosis without dementia. Now it's been approved and cleared for patients with Parkinson's disease with or without dementia. Number 11, anticholinergics. Remember, we talked about anticholinergics being one of the first, the oldest medication that were tried actually during the time of Charcot. Now we still have them, we still use them. This includes medications like trihexyphenidyl, Artane, Cogentin, Benstropin. These are oral medications. They have to be dosed. They have short half-life, so patients have to take them either twice, 3 times, or 4 times daily.
Yeah, I can see what he's saying on here.
So these are the medications that have been approved here by the FDA for patients with Parkinson's disease. Every patient responds differently to these medications. Some patients will respond to such a low dose of medication A, some don't. Okay? Which means that we don't have full understanding of the neuropathology or the pathogenesis of Parkinson's disease, the way that these patients, or the way that we metabolize, we clear these medications, the way that we react to these medications. And on top of that, from the beginning, when we see patients, are we diagnosing patients with Parkinson's disease? Or we think that they might have something else, Parkinson's lookalike, or atypical Parkinsonism, where patients might show some response initially, but down the road, after several months, a year or so, they might start showing other red flags or exclusion, that this might be something else that looks or mimics Parkinson's disease. Now, the other form of treatment, other than medications, is device-assisted procedures and lesioning procedures. This all happened by accident back in the almost 80, 90 years ago, when patients were having these tremors, were having the symptoms of Parkinson's disease. They come with a stroke or come with a brain bleed, and they go try to ligate or cauterize or basically clamp an artery by creating a stroke. Okay, so by just blocking that artery inside the brain, and on the other side, the tumor goes away. And actually, just this morning, one of my patients who've been diagnosed with Parkinson's for a long time, she developed a stroke, and the tumor is gone on that side, okay, as a result or as a byproduct of that stroke. But now she's getting Botox for the stiffness in that valve. So during that time, back in the 1950s, before the invention of levodopa, it was a common or relatively common practice just to create a stroke, to ligate the artery or lesion the area. Okay, instead of closing the artery, let's go and do what we call thalamotomy, right? Or thalalectomy or thalidotomy. So lesion the area, so patients will have relief of their tremors, but at the same time, the side effects or the complications are relatively high. So they're not done anymore. So this theory, by the introduction of levodopa and medications, no one was doing these interventions or these surgeries. They became part of the history. But in the late 1980s, early 1990s, research was done. Rather than lesioning, why don't we send electrical impulses deep to these areas in the brain, the basal ganglia that we talked about, to see if it's going to help with the tremors, to see if this is going to help with any of the symptoms. This was pioneered by a French neurosurgeon. His name was Alain Ben Abed, French. And with his work, his co-workers' work, this led to the development of what we call nowadays the deep brain stimulation. Deep brain stimulation. It was studied initially on patients with essential tremor, which is far more common than the Parkinsonian tremors. This led to the approval by the FDA back in 1997 for patients with essential tremor. Further studies years later done on patients with Parkinson's disease that led to the approval by the FDA of the DBS for patients with Parkinson's disease in 2002. Now, the DBS is a well-known procedure. It's widely available. As you know, it's a brain surgery that helps patients with Parkinson's disease to cope with the motor symptoms. Same thing, the way that patients respond to the medication, to the levodopa, dopamine agonist, whatever medication that they're on, they expect to see the same degree of benefit, excuse me, on the deep brain stimulation. The main advantage of the deep brain stimulation is to smooth out these on-off episodes. And in addition to that, the tremor in Parkinson's disease can sometimes be stubborn. Try 1, 2, 3, 4 medications while you feel the patient that their stiffness, that their slowing has improved with the medication, but the tremor is still there. So even in these cases, even if you try 1, 2, 3, 4 medications and they're still not responding and they're still having these disabling resting tremors, this could be, and patients have had the symptoms for several years, preferably anywhere from 3 to 5 years. They're not showing signs and symptoms during that period, that this could be something else. Remember, we talked about mimickers or something that might mimic Parkinson's disease. They are actually good candidates, could be ideal candidates for deep brain stimulation. Whenever we consider deep brain stimulation, whenever we see patients with Parkinson's disease, we always think at the deep in our minds, are they considered actually good candidates for DBS or any of the lesioning or non-medication intervention? This includes, are we really confident or have high confidence that this is Parkinson's disease? If they have the symptoms for 5 years or more. Now we have other studies like the early stem talking about 3 to 5 years. That could be possible as well. Are they mostly disabled because of the tremors, the stiffness, and the slowing of the movement? And they do not have significant dementia. They do not have significant or advanced mental health issues. They don't have significant or advanced mobility or walking problems. They're not falling every day. They're not dependent on wheelchairs or walkers that they have falls every day or every other day, frequent falls. Okay? So these are considered the ideal candidates for patients with Parkinson's disease or deep brain stimulation. There are different areas in the brain that can be targeted by the deep brain stimulation, and choosing the location that depends, it's individualized. That depends on the patient, him or herself. What are the dominant or the predominant symptoms? What are we trying to target? Tremors, might choose one area. Motor fluctuations, might choose different area. Dystonia or twisting or spasms, might choose a different area as well. This is a brain surgery. We give the leads on both sides. Does not necessarily mean that you have to turn the device on both sides if the patient is different. Okay, you program the patients, you adjust the programming. You can go up, you can go down, depending on what the benefits
Anxiety and
versus
depression
the complications that can happen by the stimulation.
caused by depression. They're symptoms of depression. They're not caused by
The other symptoms, the other device or the other procedure that was approved by the FDA is the MRI guided focused ultrasound. This is relative, so the
So it seems to me.
focused ultrasound is not really a new Focused ultrasound has been there for a long time. It's been used to treat benign tumors or small tumors, like fibroids, for example, or small tumors, small lesions. So the technique itself is not new. Using the technique
Have you always been constipated as a kid?
yeah.
help patients with essential tremor is new. It started with patients with essential tremor,
Just as a little
got
girl
approved by the
sitting
FDA
on
back
the
in
toilet
July
just doing
of 2016, with studies ongoing with patients with Parkinson's disease.
Why wasn't
Years
that
later,
disclosed?
this is in the therapy for patients with Parkinson's disease.
Should have had a
This is
pre-notice
a
of that.
procedure that's done. It's non-invasive. There's no surgery with the MRI guided focused ultrasound, but patients should be able to get an MRI in the first place, so they don't have an MRI incompatible device like a pacemaker. Now most of the newer pacemakers are MRI compatible, but should be able to lay inside the MRI booth awake, basically, because they should be able to communicate with the neurosurgeon or the neuroradiologist or whoever the provider that's performing the procedure. And basically what they're trying to do is, remember that area that we're trying to target with the deep brain stimulation by sending the wire down, okay? They're trying to target that area with the focused ultrasound. It's a relatively new procedure, has become available in Texas for the last couple of years, okay? And it's the effect on patients with Parkinson's disease, especially when it comes to the tremor, is almost immediate. It's been approved also to help patients with other symptoms like the stiffness, the slowing, even the dyskinesia in patients with Parkinson's disease. I know that it's been approved by the FDA to be done on both sides for patients with essential stage, 9 months apart at least. But I believe still this research is going on for patients with Parkinson's disease to be done on both sides. So far, it's to be done on one side. Okay? And one of the things that you are aware of, that Parkinson's disease, when it hits one side more than the other. And as the disease progresses over time, it stays asymmetric, one side more than the other in patients with Parkinson's. Investigational therapies, these are the slow studies that's been going on for decades, because these studies, you don't just do the study and monitor the patient for a year or two. You have to monitor patients for a long term, because these studies are aimed not only just to help the symptoms like other interventions, what we call symptomatic therapy, but you're trying to see if these interventions are actually considered neuroprotective, where they actually interfere with the natural course of the disease, slowing the disease progression or reversing the disease progression, or hopefully curative, where basically you are actually curing the disease process. This includes gene therapy, at least enzyme replacement or gene replacement therapy. We know that this is, while it was a dream in the past, that there are certain diseases that used to be incurable that nowadays are treated or fixed genetically. Now, these are familial or genetic diseases. If we're able to go down to the abnormal protein in patients with Parkinson's disease, that's the alpha-synuclein, and go to the gene of the alpha-synuclein in the chromosome 4, and fix this gene so that starts creating more normal alpha-synuclein, that could be it. And now we have more gene editing technologies like CRISPR technology. This could be a good hope, promise for treatment in patients with Parkinson's disease. Neuron transplantation, which is basically, we said that the area at the back of the brain, the midbrain, the substantia nigra, the black matter that's producing the dopamine, this is where the degeneration starts and affecting the dopamine synthesis. If we're trying to replace or regenerate these cells, because we know that brain cells are stubborn, once they are gone, they are gone. So why don't we try to replace this with either mesenchymal transplantation or embryonic stem cell transplantation? You know that there is always, whenever you do embryonic, there's always the ethical dilemma in these situations. After all, Parkinson's disease is a slowly progressive disease that the patient, the family, the neurologist, and all of us can be part of the solution, can be part of the circle to help patients. Physical therapist, occupational therapist, speech pathologist, speech therapist with swallowing evaluation and swallowing therapy, mental health provider, neuropsychologist, or what we call the dementia specialist, caregiver support for these patients, dentist, sleep specialist, dietitian. Okay, it's a common thing. Patients are losing weight, which I believe is in some ways can be good. Rehabilitation, pulmonologist. So it doesn't mean that every single patient with Parkinson's disease has to go through this. So, okay, but it's just trying to show myself that it's not a one-man job. It's for all of us. And as long as we stand all together, trying to help the patient and help ourselves by staying physically and mentally active. We're doing ourselves the greatest favor of all, okay, by slowing the disease progression until hopefully we find really something that we can call a cure, which will make our life, my life, much easier. Okay? Any questions?
We can take questions now, and I know we are watching on time. We've got a few of them here, so I'll be the roving reporter here to get to the questions, and then you can just speak very loudly in there,
Yes.
okay? And here we go. We've got a question over here.
I was wondering if there are any tests to identify the lack of those two enzymes we're talking about. Is there a way to place
Sure, exactly. CT is specific to measure these enzymes.
Any other questions? Yes, sir.
So I myself, I'm right-handed, also tremor dominant, so this people is the same, right? Yes, is there a connection between handedness and the dominance? Where your tremor starts, where you start?
No, there should not be. Can start on any side, either side. So hand dominance has nothing to do with the onset of the disease.
I didn't have any other questions over here. I know we had a question before that they asked me about diarrhea. We know that with Parkinson's you have constipation,
Yes.
but to some of the time, does the medicine cause diarrhea?
Yes. So there are two reasons. First of all, patients with Parkinson's, people that they have that constipation, the disease actually, that's a very interesting question. So the disease, Parkinson's disease, there is always this theory that's called gut-brain theory, that the disease actually starts somewhere in the gut, down in the gut, in the small intestine. So doing biopsies in the small intestine for Parkinson's disease patients, because you know the movement of the gut, what we call peristalsis, okay, is mediated by neurotransmitters, so nerves, basically. So if you do a biopsy on the gut and look at the biopsy, look for that protein, the alpha-synuclein, you'll be able to find it in patients with Parkinson's disease. So the theory was basically that the disease starts somewhere in the gut or the urinary bladder, so low, and starts going through the nerves, the vagus nerve, okay, to the brain, and starts going, affecting sleep, acting out the dreams, starts affecting the sense of smell. And then once it reaches a higher level at the back of the brain, this is when the patient starts showing the motor symptoms. So when it starts affecting the gut, patient starts to have problems with constipation, okay, lack of movement. So it's a slow transit constipation. If the food accumulates, it will reach a pressure, food, liquids, gas. Patients can have what we call overflow diarrhea. That's one thing. The other thing, they can develop what we call bacterial overgrowth, okay, like localized bacterial infection per se. This can cause diarrhea. Constant diarrhea can also be a side effect of the medications themselves. We said that the dopamine is what? It's to motivate the gut movement, either throwing up or throwing down. Okay?
Okay, we got a note here.
About the impact of early administration of medication on the long-term. If you get Cinemat earlier, or what is that?
Thank you so much for that's a very excellent question. I get this question quite often. So the question here, early administration of the levodopa Cinemat or any medication or any intervention can have it. Could it have any effect on the disease progression? Whether maybe it progress quickly or slowly or not. A lot of studies have been done on Cinemat among other medications like Prozac, Azarin.
Oh, yeah, I'm trying to, sorry.
Selegiline, all these medications have been studied extensively. If I can show you the studies that have been done, see if there is any actually neuroprotective or degenerative effect of the levodopa among all these medications, we might reach like papers up to the roof, the ceiling, all right? We don't have any evidence, any conclusive evidence to support that early administration of the levodopa can have any degenerative effect or protective effect on patients with Parkinson's disease. It's purely, so all what we can say, it's purely symptomatic, It's to help with the symptoms. So if the patient decides, hey, my symptoms, okay, I know I have Parkinson's disease, but my symptoms are mild, okay? They're not disabling me. I'm able to feed myself, dress myself, I'm physically active, I don't want to start the treatment. That's a good option. Hey, I think that I have mild tremors, but I think I'm gonna try the medication, see how it goes. That's also a good option. Either way, it's not going to affect the course of the disease. Whether you start at day 1 or 10 years down the road, I don't think that it's gonna make the disease progress either slower or faster.
Thank you. Very good question. Another one?
Yeah, so could you comment on the neuroprotective effects of DBS?
DBS, that's basically still under investigation, all right? We know so far what we can say about DBS is what we said already about the medication is to help with the symptoms. It might have a protective effect in patients with Parkinson's disease in terms of slowing the disease progression. That's basically measured by what we call the UPDRS scale 3, which is the Unified Parkinson's Disease Rating Scale. If you compare patients with Parkinson's disease with DBS to patients with Parkinson's disease who have not had DBS, right? And the way that you keep measuring them, how they progress over time, okay? It's inconsistent. Okay? So we cannot make a definitive conclusion, all right? Because there are certain aspects that they get better with the continuous stimulation, but there are certain aspects that they're going to continue to progress either way, right? We need more studies. We need more research, conclusive research, okay, to prove that this is actually the case, that DBS actually has a protective effect on patients with Parkinson's.
Question one, just checking our time here. So take this question and maybe one more and that'll be it.
Okay. Yes, neurogenic orthostatic hypotension. That's one of the autonomic complications of patients with Parkinson's disease. We said that the autonomic nervous system, or the other word for it, automatic, things that we do not have control over. The pupillary reaction, when the pupil goes wide and narrow, same thing, the salivation, sweating, blood pressure, heart rate, bowel movements, urination, sexual function, all these are part of the autonomic nervous system. The most disabling among all is neurogenic orthostatic hypotension. You stand up from a sitting position, your heart, your brain senses the change in the pressure, sends the signal to the heart. You might feel lightheaded for a fraction of a second, but your heart will be able to compensate by pushing harder. So the blood flow, the pressure will be maintained inside your brain. That's the normal response. With Parkinson's disease, this response is blunted. Is why? Is what? Why does this happen? Because dopamine actually is the parent drug for norepinephrine and epinephrine, these vasopressors. Okay? So the response is blunted. Patients might have the neurogenic orthostatic hypotension. The best way to start with patients with Parkinson's disease is to treat them conservatively. All right? Keep the fluid or keep the tank full. Keep your tank full. All right? Now, this might require some fine-tuning if the patient has heart failure or kidney failure or they are already fluid overload. Okay? But here in Texas, we need to make sure that our tank is full. Plenty of fluid, drink water, cold water. Okay? This is among the things that we encourage patients to do, especially in the morning when they wake up. You've been asleep for several hours, okay, laying flat, and now you're gonna stand up and start your daily chores. Okay, so you expect that this is the time the blood pressure is going to plummet. So you can have like a whole glass of water, 8 ounces to get you going, right? Water alone is good, but it's not enough. And things that are rich in electrolytes. Okay, while I'm not commercializing anything, but things like B8 or Gatorade or Pedialyte are good resources for electrolytes. So they help maintaining the water. Okay? When you drink water or liquids that have electrolytes, they will last longer in the system. So you get the benefit from these liquids or fluids longer duration. Of course, with conservative measures, might recommend wearing high elastic stocking, not just below the knee, but something that goes high. Mid thigh, high thigh, or even wearing like lower abdomen, or even wearing abdominal binders sometimes can help, because kind of like push over the veins in your belly, trying to push over the venous system all the way to your heart and then to your brain. When you sleep, do not sleep with your head flat. Try to sleep with your head at 30 degrees or so. Okay, so your head is actually elevated. The other thing is exercises, stretching exercises or pedaling. Okay, right? These are among the things. Range of motion exercises, compression exercises. These are among the things that help also pushing the blood flow from the veins, your legs, your abdomen, up to your brain. Now, there are medications that have been approved or cleared or used off-label for patients with neurogenic orthostatic hypertension. Florinef, which is kind of like close to cortisol. It's not similar, but close to cortisol. And it helps basically raising the blood pressure by keeping salts in the system. Same thing with midodrine. Midodrine is kind of like, it's a vasoconstrictor. Okay, so as to keep the blood pressure elevated. The one that was approved by the FDA is droxidopa, Norvera. It's to be taken once, twice, or 3 times a day. It's basically a precursor of norepinephrine. Basically, when it gets into your system, it becomes like norepinephrine is trying to increase the blood pressure. The problem with these medications, I don't usually go with these medications unless it's really severe, bad neurogenic orthostatic hypertension, because they come with their side effect profile. The most common, which you can imagine, is when you're up and active, right? You want these medications to help support your blood pressure. But once you're sitting, inactive, or laying flat, okay, the blood pressure can overshoot. Okay, so it can go high, 180, or sometimes even like readings in the 200s. And this is a problem that's particularly peculiar in patients with Parkinson's. So Parkinson's look alike. That's one moment the blood pressure is 80, the other moment the blood pressure is 200. So 80 is not good, 200 is not good. So always trying to fine tune by conservative measures before pushing, okay, for these medications. Right? Does that answer the question? All right.
That was an excellent response, because I get that a lot from people. And the low hyperlipidemia you were talking about, and the neurogenic orthostatic hypertension does cause dizziness. That was the only other thing that she said. That's part of the dizziness.
That's good.
That's part of the dizziness right there. This has just been fabulous. I'm going to go on, and because of our time, you gave us so much information, and thank you. After the meeting, so you get to stay, right? So you'll be over here so you can ask some questions. So we've got just a little bit more left in our program. Okay. So what we've got going on right now is this is usually where I tell you about the exercise. Oh goodness, we've got people leaving. Don't leave. This is going to be so good. So anyway, I just looked up and the doctor was just fabulous. We have gone on here. Okay, exercise. Angie with Power for Parkinson. And I did want to just go and show you, this is an example of what our class looks like. And Angie, do you want to do your exercise up here? Okay.
And I'm going to do it seated.
Ready? So, again, if say this is really good, because remember, part of your other exercise in this meeting is putting up chairs. These people say they could be put up chairs. Yeah, so don't leave just yet. Totally. Okay. Anyway, this is Angie with Power for Parkinson's, and I'm going to go and do a stop share right here. And if you could sponsor them, or whatever, so that y'all can see it really good for our Zoom crowd. Okay, and this is Gardenia Strong, also known as Garden. Garden is works with Power for Parkinson's. Both these ladies do. So I'm gonna let Garden talk to say howdy to you real quick.
Hi, how are we doing? All right, so that was really an amazing presentation. In fact, I was going to do a little spiel about the benefits of exercise, but he covered a lot of it. So let's just this and let's exercise and just get a little moving, and then let's just notice how you're feeling right now in this moment, and then do whatever Angie tells you to do, and then you're gonna feel a completely different way, and that's the power of exercise. So essentially, I'm giving this little spiel since we're running out of a little time, but I'm going to be able to do her full magic. So without further ado, it's Angie. In fact, you can find me every single week from Baptist Church in the Education Building on Wednesdays from 1 to 2 if you want to come take our new Georgetown Parkinson's exercise class. And a lot of you do take that. And we're also looking for volunteers at the class. So if you're really, thinking of participating as a participant or a care partner in the exercise program, but you're like, I still want to come hang out with this group, you can do volunteers to help us spawn, help us set up help us pass out equipment and fun stuff. So if you're interested in that, please come see me after. I've got some flyers, and we're here every Wednesday from 1 to 2. So let's let Angie do her magic. She's not going to be able to hold this mic while she teaches, so she's just going to yell at you. But don't be too intimidated. It'll be fun.
Cases. Happy Friday to her. It's Friday to her. So instead of Thursday. So we talked about not standing up quickly. So those we're going to do this seating, but if you feel voice, but I'm going to show the exercises seated.
Can I continue to use the mic as much as I can? Stand by you, but the deal is we're also doing this on Zoom, and they need it to hear.
All right, everybody take a big deep inhale up and exhale out. One more inhale up.
Moan, get it all out. Okay.
This next one was more positive. Let's inhale up. And let's say, here. All right. Let's do some shoulders back. I'm doing it with handed. All right, other direction. Okay, great. Let's take the neck down and to the side and to the back. The other side. All right, take your right hand overhead and let's do a little stretch and then back up. Great, switch hands. Other side. All right. Okay, this is gonna be hard to do. So let's just do some little bit. Let's start to move our back and our sitting a bit. Overhead. Taller and taller. Oh, you feeling like you can move? Let's do our hands out front. Opening those fingers. All right, circle the wrist. All right. Oh, feels good. Shake it off. All right. Where's my DJ? Yeah, this is going to be tricky with one hand. We'll do. Go.
Garden. And thank you everybody who came. Dr. Shawagfeh is still here. If you do have some questions for him, we do have door prizes. Now look at the odds. Your odds are doing really good because there's a lot of people who left. Great door prizes. And here they are. We'll have to ticket real quick. We've got, let's see, great exercise that we did. We've learned a lot. Golly, excellent presentation from the doctor. Next month, Dr. Swallow will be here to be our speaker. That's going to be October the 26th. We'll be talking about Halloween too, maybe. We did our door prizes. I want to thank all my volunteers. And as a reminder, particularly if you're new, let's put up tables and chairs. So usually I've got a couple of folks, sending my lead person to help with chairs. Talk to Patty, but we'll get a chair holder over here for too. So thank you. You can just vote up chairs. Thank you. Have a blessed day, and I'll be in touch by email. And bye. See you next month.